I'm going to try to discuss EUS-guided gastroenterostomy. What is it? How to do it? Why? Who can do it? And when to do it? So from a clinical standpoint, EUS-guided gastroenterostomy is used for patients with malignant, unresectable gastric outlet obstruction as a palliative procedure instead of surgical gastrojejunostomy, none today performed laparoscopically, or because many of these patients cannot undergo surgery, they're too ill, duodenal stent, which is at least less invasive approach. So in theory, gastroenterostomy will combine the minimal invasive properties of duodenal stenting with the long-term efficacy of surgical gastroenterostomy. From a procedural standpoint, the procedure is done under EUS guidance. The small bowel is imaged from the stomach, and a lumina-posing metal stent is placed across the walls to create true apposition. This was demonstrated 12 years ago in a porcine experiment by Dr. B. Muller and Dr. Shah in the United States. So in addition to gastric outlet obstruction, gastro or jejunogastric or gastrogastric anastomosis are also performed in patients with altered anatomy where traditional ERCP is not feasible, or in patients with afferent loop syndrome. So in either example, there is, similar to gastric outlet obstruction, a least invasive and least effective traditional endoscopic approach. In the case of altered anatomy, will be enteroscopy-assisted ERCP or antegrade stenting for afferent loop, and a more invasive surgical or radiological interventional radiology approach, so laparoscopically assisted ERCP or PTBD. So this we can do with lumina-posing metal stents under EUS guidance. So unfortunately, we won't have time to discuss these other two indications. We will focus on gastric outlet obstruction. That will be the amended title of my presentation, right? So this novel procedure replaces traditional attempts to create the same bypass under endoscopy that was tried like before EUS-guided gastroenterostomy using magnets. It's an elegant procedure, but magnets are cumbersome to be placed. Also using so-called nodes, entering an endoscope into the peritoneal cavity and either suturing or creating. These approaches never enter clinical practice. Then one brief comment about the name gastroenterostomy. This procedure is performed at the duodenojejunal flexure or trites angle, where the duodenum changes its name to the jejunum. So if we enter after the trites, it will be a gastrojejunostomy. If we enter under EUS before, it will be a gastroduodenostomy. To cover both variations, we have this name. So now that we know what it is, how to do it, the standard technique is the double balloon tube, or EPAS, where a double lumen balloon is a tube with two balloons is inflated to identify the trites angle, and the lumen in between is filled with fluid. So we have a clear identification of the small bowel at that location. So the problem is this tube is not available commercially outside Japan, and it's also very cumbersome to use. So we have to use other approaches to make up for the lack of the double balloon tube. And the steps for the procedure are identifying the small bowel, accessing with the catheter, deploying the stent, and confirm proper placement. These are the four sequential steps that we need to be able to replicate without the double balloon tube. And identifying the small bowel is challenging because it's a very small anatomic structure filled with air, with interferes with ultrasound. It's small, mobile, and very close to the transverse column, which can be mistaken for it. So traditionally, historically, there were the wire-assisted methods to confirm small bowel. So balloons that were passed over a wire were placed distal to the stricture and identified under EUS. Wire-assisted methods were developed in the United States. So the balloon was passed, identified, punctured, and then the wire placed through the needle distally, or retrieved with another endoscope, pulled out of the patient's mouth, so that under dual traction, the stent could be placed, or even threaded with an endoscope to place retrograde. Most of these cumbersome methods are nowadays abandoned in favor of fluid-based small bowel identification techniques. So basically with fluid, we identify the small bowel. If we inject it under real time, we can make sure we can see under our eyes, under EUS, that this is precisely the small bowel and not the transverse column. So once we've identified the target with this fluid, we can access. But let me just detail how can we make up for the lack of the double balloon tube. The most commonly used method is the nasobiliary tube method, which is used worldwide. And in the United States, they first used direct methods, whereby they injected fluid through a needle or through an endoscope passed across the stricture. But with the nasobiliary drain or orojejunal catheter method, we can confirm real-time distinction. Then there's emerging consensus that the stent, hot stent, should be placed freehand, not over a wire, and we confirm proper access by the boiling water sign. When the tip of the catheter creates a cloud, which is bubbles boiling from the heat, then we are sure that we are into the small bowel, not in the peritoneum. The LAMS is nowadays deployed inside the scope, and then for confirmation, we just watch the fluid return. All of these steps and the way to perform them evolve gradually over 10 years. There's less disagreement on the last 4 steps. The combination on the variations used on the first 2 steps give rise to a number of different acronyms that are really not important. The important thing is the concept. And I'm going to show you how we do it with this orojejunal catheter method. We have everything ready. This is a type 1 stricture in the pylorus by gastric cancer. We use a 3-layer catheter, and even if the stricture is here in D1, we try to get across the triangle, and after we have the guidewire past this triangle, we exchange the positioning catheter for an irrigation catheter. It's a commercially available 8.5 French nasobiliary drain. We monitor under fluoroscopy that it gets past the trides. We remove the echo endoscope or the therapeutic gastroscope and insert it in parallel. And we haven't injected any fluid, any contrast. We have a clear operating field. And it is only then that we start putting some contrast. We then connect the nasobiliary drain to a water pump and blow up our target that we've already identified while we have the lamps already in place. So by putting contrast, we have 3 centimeters, we have good alignment, and we can go perpendicular until we see the boiling water sign. And then we deploy distal flange under EUS and the proximal flange of the stent under endoscopy. And it is only then that we put some methylene blue through the catheter so we confirm proper placement. This is a very reproducible way to do it, despite not having the double balloon tube. Why do it? Basically, clinical outcomes are much better done with the alternative enteral stenting. In particular, the rate of gastric outlet recurrence is only 4% with gastroenterostomy, up to 30% with enteral stenting. This is a small retrospective series, one of the earliest. However, same results hold up in larger meta-analysis with over 600 patients, and also in a prospective randomized trial that were led by the Chinese university group here. This is the patency with gastroenterostomy, and this is with duodenal stent, clearly much better. And also the outcomes are better compared to surgery in this retrospective study. Time to oral intake is 1 versus 3 days, to full diet 2 versus 8 days. Adverse event 6% versus 31%, and a hospital admission 4 days versus 8 days. So this is as effective as surgery, with much less invasive. And again, same results with larger retrospective study. We don't have yet the prospective data on this, but are expected shortly. So who can do it? This is a challenging procedure. It's been said that the learning curve involves 25 procedures before proficiency is reached and 40 before mastery is reached. There are discrepant findings from others investigators at 7, stating the number for proficiency is only 7 supervised procedures. But at any rate, there is a 10% chance of stent misdeployment, which is in fact a perforation. And the important thing is not to panic. Most of these problems can be fixed by endoscopy. This is the easiest way to do it. You see peritoneum because the distal flange was misdeployed. We identify the perforation with a guide wire. We typically would do this under CO2 insufflation. We monitor capnoperitoneum, but with the wire, we can identify both all the edges of the perforation and clip close with this device. And if the stomach was clean, which is usually the case because we use NG suction prior to the procedure, really nothing happens. We place a duodenal stent, and this is just like not really a complication. So how to get started in gastroenterostomy? Of course, one has to be fully trained in ERCP and interventional EUS. I would say that you have to work at a middle to high volume center that's typically defined by 200 procedures a year. And you have to be very familiar with the type of lamps that you're using. So you're going to use a lamps. Don't let gastroenterostomy be the first time you use that type of lamps. And I say that because there are several hot lamps available on the market. Spaxus has also been tested in a porcine model. And also there is a pilot preliminary series from Italy, 25 patients, 100% success rate. But if you're going to change from the traditional lamps to these new lamps, you have to try it on a different target. And of course, there's specific requirements that I would recommend, like study online material, talk to experts, attend meetings such as this one. Hands-on training using animal models would be ideal, but it's not widely available. On-site observation or proctoring is also very useful. And people, when they start doing this, usually they use a WhatsApp a video, phone call, and get guidance, and that also works. Maybe in the future we won't have to worry that much because we will have new devices available. This will probably be soon on the market, makes the procedure very easy, very reproducible, probably like pseudocyst drainage. Who knows? We will know shortly in a few years. So when to do it, before I finish, there are two, for gastric outlet obstruction, two basic indications. Like in centers like ours, we use for primary palliation of all unresectable malignant gastric outlet obstruction. At other centers where the technique is developing or insurance would not cover for the cost of the stent, this is used as a second-line palliation when duodenal stent is not feasible or not working on for that 30% of stent dysfunction that occurs. I would say that one should have a higher threshold when there is very limited life expectancy, when there is ascites, or there are some other anatomic contraindications. It's interesting to note that the recovery of oral tolerance is not immediate. This is 64 patients. More than half of them were nil per os. Some of them were able to tolerate liquids. And at day 7, only a few of them were able to eat a full diet, but on day 30, half of them were able to eat a full diet. Most of them could have some diet, liquid or soft. There were some early deaths, or some patients still failed to be able to eat. This is what happens when you assess prospectively the recovery of oral tolerance. There are other symptoms that improve in the study, not only vomiting and loss of appetite, but also constipation and pain. And this is probably because gastric emptying is much better when you use lamps to create gastroenterostomy than when you have duodenal stents and the food has to go through a non-functioning part of the small bowel. So I would say that a lower threshold is warranted when there is concurrent malignant biliary obstruction. This is the classical approach to palliation. We have a duodenal stent and a biliary stent, but both stents get in the way of each other. So the duodenal stent will hamper biliary drainage, and the biliary stent may hamper gastric emptying. So we started doing bypassing this instead of ERCP with choledochoduodenostomy. This is called the second generation double endoscopic bypass. However, when you look at functional outcomes, all combinations that include gastroenterostomy, whether it's with transpapillary stenting, hepaticogastrostomy, or choledochoduodenostomy, has a much longer dysfunction-free survival. So when there is biliary obstruction, gastroenterostomy is much better. It can also be used for benign disease in chronic or acute pancreatitis, where duodenal stents cannot be used. And as I said, is a much more cost-effective alternative than enteroscopy or lap-assisted ERCP for biliary access and also for afferent loop syndrome. So, gastroenterostomy is a novel procedure where a luminopusimoidal stent is placed under EUS, mostly for gastric outlet obstruction. It achieves superior outcomes to the surgical or endoscopic alternatives. Lacking the double balloon tube, we can use an orojejunal catheter very reliably. Of course, you need to be trained, specifically in interventional EUS and also in the procedure. And it's gaining front stage for the palliation of malignant gastric outlet obstruction. Thank you very much for your attention.